This is episode 698 of the Rio Grande Foundation's Tipping Point, New Mexico. I'm Paul Gessing, president of the Rio Grande Foundation, New Mexico's free market think tank. You can find out more about the foundation at riograndefoundation.org. I am very pleased to be joined this week by Troy Clark. He is the president and CEO of the New Mexico Hospital Association, and we will, of course, again be discussing New Mexico's medical provider shortage and policies relating to healthcare in the land of enchantment. But thanks for coming on, Troy.
Good morning. Thank you. Glad to be here, Paul.
Yeah. So we met at a recent event that was put on by a Republican group, a FRW, Federation of Republican Women's Group, and you gave a presentation there. And I thought, man, this guy has a lot of interesting information about hospitals and the medical issues facing New Mexico. And so we talked, and after the session, of course, when life slows down just a skosh, we were able to work this out. But why don't you share a little bit about yourself, how you got into this position, and your association in the hospitals that you represent?
Yeah, that was a great event to be at. I was privileged to be invited to speak there. I always look to take the opportunity to share information because I think we all make better decisions and take better positions in life when we have more information about really what's going on out there. But my background, I've served in this position for about 5 years as the head of the New Mexico Hospital Association, where we represent 47 hospitals across the state, which is nearly every hospital in the state. There's a few that are federally owned, like the VA and the Indian Health Services, that are not our members. But aside from that, we really work with every other hospital that's out there, both the traditional hospital that people think of when they see the blue H on the freeway or an emergency room, and surgery departments, labor and delivery departments. But also there's about 10 post-acute hospitals, as we call them. They're either behavioral health facilities, long-term acute care facilities, or physical rehabilitation hospitals that people also have need to get the care they need to get back to their life at home. So we represent all of those. By way of background, I actually worked in the healthcare industry, both running physician practices, and then for about 20 years ran hospitals across the country. But we've been here, blessed to be in the New Mexico area with my family for a little over 20 years. Came here back in 2003 with the Ardent organization, who owns the Loveless Hospital System, to help create Women's Hospital. And I've been involved with Loveless, with the UNM system, and opening the hospital on the west side for them, Sandoval Regional Medical Center, and then spent a few years with Presbyterian, back kind of in my roots or my niche of really connecting with rural hospitals and rural communities throughout the state.
So your experience primarily is here in New Mexico, as opposed to having worked in any other states, or have you worked in any other states?
Prior to coming here, about 5 years. So I mentioned the 20 years running hospitals, or about 5 years before that, I worked in healthcare, lived in the Nashville area. I actually started off with an accounting degree, moved to Nashville, Tennessee, where my wonderful wife was from, or is from, and spent time in the accounting industry for a couple of years, but then worked in healthcare, and have worked in states across the country, from California to Florida, Ohio down to Texas. So all across the country for the first 5 years of my career.
So that's one of the things that I wanted to talk to you about, like kind of as an initial issue to discuss is, and maybe it's more based on conferences you go to and folks you visit with from other parts of the country. Just in chatting with those people, what is the situation in other states vis-a-vis hospitals versus New Mexico? How different are the issues that we're dealing with, or is kind of a hospital's dealing with all of the same basic issues, or maybe just in different quantities or different nuances?
It's really a mix. There are some aspects, since Medicare is so broad across the country, and people, 80% of the healthcare dollar you're spending in your lifetime, you usually spend the last 10 years of your life. For most of us, we hope that's in our Medicare eligible years. And so the Medicare program brings a lot of similarities to healthcare, whether it's hospitals or physicians across the country. And then from each state, you actually have your own nuances. Some of the nuances that drive New Mexico in a different way than many other states. We have 44% of our population, 43%, I think it is actually, of our population who's on Medicaid. Most states average 15 to 17%. So we are the highest rate of Medicaid recipients per capita in the country. With that, that brings its own challenges and nuances that many other states don't have. I interact with the other 50 state hospital association executives across the country, so I get to talk about these differences and nuances. And clearly, our level of Medicaid involvement in the Medicaid reimbursement and policy decision making is a uniqueness to New Mexico. Another uniqueness is our medical malpractice environment. Unfortunately, we're the worst environment in which to practice medicine when it comes to medical malpractice. I know there's some legislators who want to pick and choose other metrics and say we're not the worst, that we're average, but actually it's been noted in several different publications that we are the worst medical malpractice environment, one of the worst states to practice medicine in.
All right. Well, let's get into the meat of our conversation here, and we'll start with the legislative session that just wrapped up, of course. Medical providers, medical provider shortages being something that was widely discussed before the session. I think it's safe to say there was a lot of discussion during the session. Not a lot happened during the session, but one bill did pass, and we're not fans of this bill, and I want your take on it. HB 586. Now, this one, just on the number, you look at it and you say, if you really follow the legislature, you say, well, this isn't somebody's first priority bill that they came up with and they've been vetting and working on since time immemorial, because that would be HB1, HB2, SB1 or 2, whatever. This is 586. It was a dummy bill that was run relatively late into the session, and it gives the Secretary of the Healthcare Authority the ability to review proposed transactions, e.g., acquisitions and mergers that materially change control of New Mexico healthcare entities that could negatively impact the availability, accessibility, affordability, and quality of care for New Mexicans. Now, that's obviously a big enough description to drive a truck through. So we're not fans. I suspect you're not a fan because this is directly antagonizing to your industry and your members. But tell us, stuff we don't know about HB 586.
Yeah, let me provide a little background on that, because at the end we actually came in a neutral position on this bill, and here's why. You call out, start with the number. It is a bill that was put into place as a dummy bill near the end of the session. Its predecessor was SB 14. So numerically,
A little more, yeah.
Makes a lot more sense, right?
Right.
And there was a lot of work. This bill actually started last year, a year ago in the last session. It was a unforeseen and unwanted surprise bill popped up in the middle of the 30-day session. So you can say the end, because the 30-day session, it was a short session, but within the last couple of weeks of the session, this concept of having oversight and authority over hospitals and transactions popped up. In an effort to try and ramrod something through, we stopped the progress of that bill and agreed and said, yes, there are some things happening nationally that we don't want to have happen in New Mexico. We agree with that as an industry. However, your attempts to the bill sponsor, we said, your attempts to mitigate this are so far overreaching that we agreed to what amounted to a 1-year stopgap bill to say, you haven't brought this up and discussed this with industry at all, gotten input. They put into place a bill that provided full confidentiality of our information and records for our hospitals and their staff. for a 1 year period of time. Had a sunset that was sunsetting. In fact, it does sunset June 30th of this year.
Now, just to be clear, are we talking about the original bill, SB 14, or is this the new bill?
I jumped back actually even before that to last year's bill, and
Okay,
I don't
last
remember
year's.
the bill number.
That's
So,
fine.
so that started the
All
process to
right.
say we'll put something in place that has some very minimal guardrails in there in order to have a conversation throughout the summer. And so the office of superintendent, the secretary or superintendent of insurance here in New Mexico, along with Senator Katie Duhigg, worked throughout the past year in the interim session, having a number of different conversations and hearing our concerns, hearing public hearings, to where we felt that by the end of December, when we finally saw their draft bill on New Year's Eve,
It's an interesting time to drop a
we
bill.
felt very concerned that we had not been listened to, that the concerns of the industry were ignored in that bill. And it was once again very overreaching and overexpansive. And that's what resulted into Senate Bill 14 that was introduced.
Okay.
Throughout the first weeks of the session, a number of discussions. We'll just speed time up and say that that bill ended up not passing. It
Right.
got to the Senate Judiciary Committee. Concerns over the constitutionality of the authority of the superintendent of insurance, concerns over the impacts to access to care. And we really started, let me jump back and say, we started this session, whether it was this bill or any bill, with a position at the New Mexico Hospital Association that said, if there are any bills that negatively impact access to care, we will be against them. If there are any bills that are out there that substantively and with quality improve access to care, we will be in support of those. Access to care is our number one issue in this state for healthcare, if not our number one issue. There can be some arguments between crime and that. So with that as the background, let me then jump back in. That bill ended up dying in Senate Judiciary. There was a lot of concern from the governor's office, who approached us and said, we need something in place to make sure that some of the things that have happened on a nationwide basis, and I'm not sure if you're familiar with Steward Healthcare, but there's a hospital company, Steward Health, who had hospital operations in a number of states, had a CEO who allegedly, I think through everything we've learned through the media, probably did some rogue things, put that company into a position that ended up filing bankruptcy and put healthcare access in those various states in a lot of turmoil. And we recognized that we didn't want that, however, to happen in New Mexico, but we also did not want things to be so intrusive that it stymied hospital operations, or even worse, that it negatively encouraged, or I guess let's not do a double negative, that it discouraged the interest of investment in healthcare in the state of New Mexico, either from within or from without the state. We are a extremely rural state, as you know. Our hospitals, we only have 4 communities that have more than one hospital facility in them: Santa Fe, Albuquerque, Las Cruces, and Roswell. Every other community that has a hospital is a sole community provider. It is very difficult in today's environment in healthcare to survive with all of the rules, the regulations, and protocols that are required to survive as an independent facility. There are some that are doing a good job and holding on. There are others who reach a point that they need the efficiency, they need the expertise to bond together with other facilities in a system relationship, an affiliated relationship, an merger or an acquisition, simply to keep the doors open to providing healthcare in those communities. We did not want that to be impacted. Senate Bill 14 would have caused, had it passed, a number of concerns and issues that we believe would have highly discouraged investment in, or the ability for hospitals to be acquired, merged, or affiliated with throughout our state. So after it was killed, House Bill 586 was introduced after much conversation with us at the Hospital Association, with the Medical Society, to say, what are the principles that you could live with in a bill that gives us the protection to not have what happened with Steward Health and some other things, some other entities on a national level, but yet still give you the protections that we don't discourage investment in New Mexico. The number one issue for us was confidentiality. There are so many records. Patient confidentiality probably has never been a problem. There's enough national uh, language and regulation statutes around what is known as HIPAA. I think most people are familiar with that protect patient privacy. But when you go through a merger, a transaction, or an affiliation, all of your books, all of your information is open. Personnel files, all of your contracts, all of your supply agreements, things that are both competitive in nature that a competitor should not see, but also privacy issues when you get down to HR files. We felt very strongly that we needed full confidentiality, and what was originally being proposed in Senate Bill 14 was not full confidentiality of a transaction. And so we do believe and agree that communication to a community is fine and appropriate to let them know what's happening. That's the healthcare provider in their community. But full confidentiality needed to be maintained, and the law needed to be restricted to only mergers, acquisitions, healthcare transactions. Senate Bill 14, another big problem with it is it expanded out beyond those into if a hospital was to change a contractual relationship with who provided their physician coverage for their emergency room. It would have to go through a review process through the superintendent of insurance, which by the proposed law gave them up to 120 days to make a decision whether they would approve that or not. Contracts that hospitals have with these physician agencies to supply the physician component of an emergency room can be canceled within 60 days. That left a major problem that if someone can cancel a contract within 60 days, but approval for a replacement could take 120 days, that would leave a community in a position they potentially would be left without emergency room services. And you can fill in the blank, whether it's radiology services, labor and delivery services, ultrasonography, etc. And so the expansion of Senate Bill 14 to actually implicate all operations within a hospital, not just the ownership or the governance of a hospital, was very problematic. So we end up with HB 586. Would any industry like there to have no regulation? Absolutely. That would have been our preference. But we got to a position that we were neutral because I believe the governor's office and the sponsor from the House, Representative Rena Sapansky, sat down, listened to the concerns we had, and said, if we don't address these, we will negatively impact access to care either immediately or in the future, especially in our rural areas. And these are adamants that must have, and that's what resulted in House Bill 586.
Hmm. Wow. Well,
sorry for the short answer.
Yeah, we talk about the sausage being made in Santa Fe, and I think that's as good of a illustration of the sausage making process as anybody has ever given on Tipping Point, New Mexico. So almost 700 episodes in. Thank you for that. I hope that people can still, if you're eating at the time, I hope you haven't lost your appetite. Let's just go with that. But okay, so from a free market perspective, I suppose you can understand why we don't particularly care for the legislation, although you're kind of you would say that you and your association are holding your nose and you're not going to really push hard. You didn't push hard against this thing at the end of the day.
No, I mean, I would couch it this way to say, yeah, in the free markets, obviously, are entities, whether they're owned by the state, owned by the county, they're not for profits, whether they're investor owned, they are businesses that have to run and have to survive. Every time we add additional regulation, that discourages or inhibits the ability for a business to grow. So, from that standpoint, it's difficult. On the other hand, we also see the bad actions of other actors elsewhere that we don't want to have in this state. It would be problematic for us if the Stewart Health situation happened in New Mexico and we had communities that we were trying to save the hospitals. So we looked at that, and then we also looked at really the makeup of our legislature and said, this may be the last time that we get to have this much influence in a bill to getting it drafted the way it can be palatable to live with. And that really drove that decision to say this is something that we were heavily involved with to really get our point taken, which we felt did not happen with Senate Bill 14.
So one further point on this, and I realize we've kind of done a very deep dive into this one specific piece of legislation, but I think that's very important. Now, Uh, it is something that was mentioned before the legislative session that some in the legislature, some progressives, felt that one of the big issues, the problems in New Mexico and its healthcare system and with its medical provider shortage is the existence of private equity firms and other money interests that invest or de-invest in New Mexico's healthcare sector. Now, this is obviously a legislative response to that kind of thing. This is all about the investors and where that investment comes from and what freedom they have. Uh, I believe this is mistaken thinking and the stuff we're going to talk about in a second. I think you and I are going to agree that that is the much more impactful. These are the more impactful issues when it comes to New Mexico's healthcare system. But I just want to gauge your view on that. Is that broadly speaking your understanding of it, and do you agree with my assessment?
No, I think you've picked up a point here that nationally there is a big voice, there is a mantra out there, anti-corporation, anti-private equity involvement in just about any industry. For decades, there has been a sector of our population who do not believe there should be for-profit healthcare. That's another view and perspective. I think these have boiled up over time, which I think is disappointing that there are, and I come from a unique perspective. You go back to my background, I've worked for a state owned facility for UNM. I've worked for not for profits for Presbyterian Healthcare, and I've worked for profit entities in Loveless, just in the state of New Mexico, on top of the other entities I've worked for throughout the country.
And just to be clear, those three names are household names throughout New Mexico, and they represent three different models. Broadly speaking, where do your members fit in amongst those models? Are they primarily, or maybe you have those numbers off the top of your head, but what is the general makeup of the hospitals in New Mexico?
So we have a broad range. We have the highest number of private equity owned facilities, for profit entities in hospitals in the country, percentage wise, in the United States.
Okay.
And with that, that's why I look at my background and say it's easy for a number of people, and I think this happens with the media all too frequently and with our legislators to grab onto sound bites. It's easy to equate and say private equity equals greed. Private equity looks to have as their number one focus only extracting profit. I think a big miss in all of that is a successful business does not maintain success or achieve success over time through bad operations.
Right.
In all of my time in working in all of the hospitals that I've worked in, the various structures, but especially in for profit, there's kind of been an underlying saying if you do the right thing and you focus on the right things, the financials will work out. You have to provide good quality care or you're not going to have a successful enterprise. For profit entities, whether they're private equity, whether they're publicly owned, or whether they're individually owned, are not successful by providing bad care, by being intrusive to their employees, by creating environments where medical malpractice takes place. Across all those three different things I just talked about, people behind those policies like to make those comments that say that's driven by a motivation by private equity. Nothing could be further from the truth. A successful business that drives financial returns for investors in the for profit arena is done by providing a good and successful business that provides the product and the service that is intended to. The nice thing in our state, even though we have the highest number of for profit or investor owned entities in our state when it comes to hospitals, we have not seen this turnover. Some people often refer to it as trading cards back and forth of hospitals from one owner to another. Many of our rural communities would not have a hospital were it not for an investor owned facility. We have one investor owned facility in Las Cruces, New Mexico, that's been there for 2.5 years because it opened 2.5 years ago, not because it's been traded from one to the other. Aside from that, the ownership of our hospitals in our state have been the same today as they are for the past 10 plus years. some of them as long as 20 years. They have become part of the community. Hospitals are run, regardless of their ownership, by people who live in those communities: the doctors, the nurses, the phlebotomists, the respiratory therapists, the maintenance folks, the dietary folks. They live in those communities. So, regardless of whether it's out of state, whether it's for profit, not for profit ownership, those hospitals are run by local folks, and we would say New Mexicans, but even more so, people directly from those communities. So it's an important part that's out there. Are there bad actors? Yes, there are some bad actors. There are some bad actors that have happened on a national level that have gotten attention. But part of the issue, Paul, when you talk to these people, when I talk to these people and they bring up private equity, I say, well, who exactly is private equity? They don't have a definition. Sometimes their version of private equity includes publicly traded companies. Sometimes it includes individually owned facilities. It ebbs and flows. In fact, one of the national studies presented, or one of the professors of that did a national study on private equity, that claimed that quality is worse by 25% at a private equity owned facility than a non-private equity owned facility. First of all, didn't call out that the increment of 25% was such a small, minute number that 25% sounds pretty salacious, that's 25% increase in bad outcomes. We're talking about 0.002% that increased to 0.0022%. Yeah, mathematically, that's a 25% increase. But it was also such a small sample size that when I questioned him, the private equity owned facilities that he engaged and reviewed in his analysis were all urban facilities in cities with populations of 2 million and more. Totally irrelevant to New Mexico, totally irrelevant to the rural nature of what we have. We don't have a community in our state that has 2 million or more people.
Right. The
That's our
state has
entire
about 2 million.
that's our
Yeah.
entire state population. And so making some of those connections, I think you've got to look and say, our position is we want to be cautious and we don't want to have bad things happen. But bad things can happen with bad actors in a for-profit environment, in a not-for-profit environment, in a state-owned facility. We do our best to try and minimize those. And so focusing efforts on private equity, I think, are very misguided. I think we need to make sure that we're aware of what's happening out there. But in our state, our investor-owned facilities, whether they're private equity owned or publicly traded, have not been problematic. In fact, some of the facilities provide the highest quality outcomes in our state.
All right. Well, you don't have to convince me, but maybe some listeners out there, and that's great. And I hope you do convince them, because I definitely concur with you. Now, something that we really need to focus on in the last portion of our show here is what didn't happen this legislative session, specifically on the medical malpractice issue and the compact issue and anything relating to the medical provider shortage as it specifically impacts hospitals and the people that, need hospitals all across the state of New Mexico. So why don't you talk about some of the issues and, as deep as you can without going too far down, because there's a lot I'm sure that we're going to have to discuss here.
Find the right depth.
Yeah.
Yeah, so there are a lot of things that didn't happen. There are some things that we believe, if you go back to my previous comment about our position, if it inhibits or in any way detracts from improving access to care, we were opposed to it. There are several bills that were introduced that attempted to do just that. A mandated nurse staffing ratio bill that would have closed beds and caused people to have to seek care outside of New Mexico. That did not pass. An economic credentialing bill that did not pass. A bill around price transparency that conflicted with the federal statute that was already in place. It did not pass. Those were good things. There are several other bills that you just mentioned that did not pass. In fact, I would even argue to say they really didn't get a fair hearing. The compacts that you talked about. For those who don't understand a compact, the easiest analogy to make it simple is to share that when you drive from here to Texas, when you cross that state line after you leave Tucumcari, but before you get to Amarillo, when you get there, you don't have to call Austin, Texas and get permission to drive in their state. There is a reciprocity back and forth between the states that say your New Mexico driver's license allows you to continue to drive not only in Texas, but in every other state in the country. That's what we're talking about with compacts. A compact allows the ability for a licensed individual in healthcare to be licensed in a single state, but to be able to have that license recognized in other states. Currently, New Mexico is only a participant in the nursing compact, but there are compacts for physical therapy assistants, occupational therapy, respiratory therapy, physicians. There's a long list of compacts, and there were 8 compacts that were brought before the legislature to try and get New Mexico to participate in, so that we would open up the access to individuals who are licensed in other states to be able to come to our state without a further obstacle of having to go through the entire licensure process. Some of those compacts allow you to not have to go through all of the testing a second time. If you think of an attorney sitting for the bar, or CPA sitting for the CPA exam, having to go through that process again. Some of them are just filing paperwork, but they take time, 3 to 6 months. That's an inhibitor when you're making a decision of where you want to work and move to. The physician compact is a little bit unique from the others, that it is a little dissimilar from the driver's license example that I gave you, in that what it allows, because it is so critical for a state's medical board to have the authority over their physicians, it does not give a carte blanche ability for a provider, a physician, to practice medicine in your state. What it does provide is the ability for all of the background information that doesn't change: where they went to do their undergraduate, where they went to medical school, where they went to residency, what historical employment locations they've been at. All of that information that is static, that doesn't change, our state medical board can rely upon the originating state's review of that information. They don't have to go back and trace to every school and every employer the details to make sure that it's all valid. It then leaves the state medical board to look at what is not static, that could change: medical malpractice claims, national practitioner data bank entries, and then still make a decision on whether to grant a license or not. Of all the compacts, we thought that would be the one that for certain would move through, because it still maintains state autonomy for the medical board. Unfortunately, none of those compacts changed. So our state sits, I know, in the physician compact. There are 39 states that already participate in that. We're one of 11 that do not. That leaves us at a detriment, that as people are looking, who have already got their license elsewhere, their willingness to come and work in New Mexico is inhibited by, they would have to go through a licensure process that right now takes 6 to 8 months to get through that process. The other thing that didn't pass, looking at time here, trying to keep up and give you the chance to ask some questions back: medical malpractice. We knew going in right
Just
now.
real quickly, those compacts were opposed by the trial attorneys, who also opposed the medical malpractice on the same general grounds that there's liability protections for those compacts. At least that's what I understand.
I think it's 2 things that I've heard.
Okay.
One is the liability protections. The other is a phrase known as state sovereignty, that we don't want, when you join a compact, for all the states to agree, the language of that compact cannot change. It says that once you join the compact, you agree to the language of the compact,
Right.
which says, here's the conditions of the reciprocity between the various states. If you pass something that changes from that, you're not allowed to be part of the compact, because you're not in agreement with all the other states. The other piece on this state sovereignty is, if we wanted to do something in the future on our own, we couldn't change it, or we would be removed from the compact. That's part of their position, is that we would lose some state sovereignty over some of those decisions around licensure, scope of services, disciplinary actions, etc.
Fair enough. All right. Medical malpractice more broadly.
Medical malpractice. I will say I have boiled down my discussion of, when asked, what is causing the access problem for New Mexicans for healthcare. To me, there's really 3 legs to this stool that are the big ones. There are a little other fringe issues, but one, the rate that I talked about earlier of the number of people we have on Medicaid, and low reimbursement for physicians when it comes to Medicaid. 44%, 43% of our population being on Medicaid. That's a significant piece of the puzzle for a physician's income. And in fact, right now, our hospitals employ 52% of the providers in our state, because if we did not, they wouldn't be here. The hospitals are subsidizing the incomes to make certain that, because of the differentials between two things, actually between all three things, between the low reimbursement they receive for Medicaid with the high percentage of their population, between the medical malpractice premiums they're having to pay, and the lack of tax incentives or loan repayment options compared to other states, make it to where a physician's decision to come to our state strictly on the financial level makes it night and day between us and other states. On the medical malpractice, I'll give an example. 2 years ago, year and a half ago, we lost a radiologist out in Las Cruces, New Mexico, that was serving one of our hospitals. They left and went to Montana. Their malpractice premiums in New Mexico were $127,000 a year. When they left and went to Montana, they informed the CEO that their medical malpractice premium was $17,000 a year. $110,000 a year that comes straight out of the income pocket of the physician. A physician is a business that provides a service. They bill and collect money for the services they provide, and they pay their expenses. When their expenses are much greater than elsewhere, that lowers their income. And so on a comparative basis, you have these situations where a physician cannot make the same or even close to what they would earn in other parts of the country. Therefore, they're earning less than their fair value unless a hospital steps in and employs them and agrees them to pay them at the going rate, so that we have to have physicians. A hospital is useless without a physician. You have to have a physician to provide the services, along with the nurses and the respiratory therapists and all of the team. So when our expense structure is so high, especially in medical malpractice, just on a financial situation, that's a big deterrent. You add on top of that a physician, when it comes, we talked a little bit about this in the compacts, when you have to go to get a new license, or when you go to get privileges to work at a hospital, or when you go to get privileges to be in network with an insurance company on an insurance plan, every one of those situations, a physician provider has to supply all of the information in order to prove their background, prove their quality, including their medical malpractice history. When you work in an environment where you have the potential of a $5 and $6 million cap on a medical malpractice claim, and you compare that to working in an environment in a state where you have a $500,000 or $600,000 exposure, you have to report that throughout the remainder of your career every time you try and do any one of those things that I just mentioned. You also have to go through an extreme, stressful situation of going through a review of the case, through the due diligence, through the all of the interviews you have to go through, all the trials, all the hearings. That is not easy on a physician to go through. They avoid them. They say, if that's the environment, I don't want to be there. So you've got the financial blockade that I can't make and I can't earn the money after all these years of education and residency and fellowship that I've put into my profession. And then I also have the deterrent coming that, why would I want to be in an environment where I have to be reviewed constantly for things that are not malpractice? They are bad outcomes, but there's a big difference between malpractice and a bad outcome. We all, unfortunately, are headed down a path to where we are no longer alive in this life, where we all die. That's a bad outcome that I think most of us don't like, but that doesn't mean there's malpractice involved.
All right. Wow. Well, that's good stuff there. Thank you for that. We don't have much time left, but we did, at the Rio Grande Foundation, we care deeply about the Medicaid program, and we believe that it needs to be reformed dramatically. That obviously raises hackles in New Mexico's legislature, and I know your members are very, very impacted, dependent. I don't know how you'd frame it, but Medicaid's a big part of what you do, as you said at the outset. The only thing, to my knowledge, that was done relating to Medicaid is a massive new $2 billion fund that was set aside. But can you give me your elevator speech on Medicaid as a program here in New Mexico, and kind of just what you see happening or not happening and impacting your members.
Yeah, Paul, I'm glad you bring this up, and it may be an area that we may or may not agree on in totality. So, a hospital is by statute at a federal level required to see all patients who come into their facility in an emergent condition and treat them without any promise of pay until they can establish that they are stabilized. It's a law called EMTALA, Emergency Medical and Active Treatment Labor Act, that requires our hospitals to care for everyone who walks through the doors until they are stabilized.
Signed by Ronald Reagan.
Signed by Ronald Reagan. So, given that, from our perspective, Medicaid, I don't look and say we're dependent upon them because we're there to provide services to whoever walks in the door, regardless if they have Medicaid, if they have Medicare, if they have commercial insurance, or if they have no insurance. So, in an effort to try and keep the doors open in our hospitals because they are businesses that have expenses, if the alternative is to have someone not on Medicaid and be uninsured and receive $0, you do find our hospitals more in support of the Medicaid program to try and help offset some of those costs so that we can have healthcare services in our communities. Now, having said that, unfortunately, historically, our Medicaid reimbursement has been below cost. And I want to emphasize not below what the hospital charges, but below what it actually costs to provide the care, to pay for the drugs, to pay for the bed, to pay for the nurses, to pay for the physician, to pay for the supplies. If you add all that up, historically, Medicaid's program paid about 85 cents on the dollar. Now, from a hospital, it was nice to get 85 cents on the dollar instead of zero if the individual was uninsured and couldn't pay, but it still was not a driver that we were dependent upon Medicaid by any means. Let's be clear about that. We still were losing 15 cents on a dollar. Last year, we were able to pass a bill known as the Healthcare Delivery and Access Act, which enabled us to access more federal funds to change that arrangement where for hospitals, we would no longer be paid below cost, but we would in fact be paid with a margin above to be able to invest and to grow, to be able to pay for increases in labor costs to our staff. But you heard me earlier say that Medicaid reimbursement to physicians is low. That act, unfortunately, that access to a federal fund program did not avail itself for any reimbursement for physicians. So we have made some strides on a federal level to access some federal funds to bring to New Mexico to help our hospitals. There's a lot of discussion going on in D.C. right now between tariffs and Medicaid cuts and budget cuts that may have impacts on that. But I want to be very clear, that did not do anything for physicians. So when it comes to the recruitment of physicians and access to care, we still have a problem that we have Medicaid recipients amounting to 43% of our population who our providers are caring for below cost.
All right. Well, uh, I think it's safe to say that we have no idea what's going to happen in Washington. The governor's talked about a special session if Medicaid is addressed or dealt with in Washington in a way that she doesn't like. We, of course, have that fund in case things do happen. And a lot of folks like myself would like to see some more fundamental reforms to Medicaid. Definitely reimbursements, understand the need to do that to attract more doctors here, but broader reforms are needed that really, unfortunately, we're out of time is what I'm getting at. So if folks are interested in your organization, they can go to nmhospitals.org. But if you have anything else to share with our listeners now that we're at the end of the show, this is your chance. So anything you want to share briefly?
Well, let me just summarize, especially I think ending on that discussion around Medicaid shows the complexity. Regardless of what our political positions are, we have realities that we too believe there should be reforms, and we want to be good financial stewards. Hospitals want to be good financial stewards of the resources we have, but we also want to be there to be able to provide access into a community. And so I don't believe the solutions to get to the reform uh, are narrow. I believe they're very complex, and we need to make certain that we look at the broader picture. Overall, I think our biggest solution, and where we probably have agreement, Paul, if we can increase the business in our state, the business industry, and the employment of individuals, getting them employed gainfully to where they are providing for themselves and able to access commercially provided insurance through their employers and not have to be on the Medicaid program, solves a whole lot of problems. It increases that reimbursement for hospitals to be able to invest in providing new services into their community. It provides a lot of economic stability for some of our small communities out in rural areas that are dying. So I think that is an area that, unfortunately, it's so complex, being very targeted with any policy adjustments out there. We need to be very smart and look at the peripheral implications on those to make sure that we don't lose access to care for those who are paying their own way with their commercial insurance that's out there. They still need to have the access to care. So we want access to care for individuals out there, but we want fiscal responsibility.
All right. Thank you, Troy. And thanks for listening to this week's episode. Find all episodes at tippingpointsnm.com or at the Rio Grande Foundation's YouTube channel. Subscribe to the show at Apple, Stitcher, or tell Google Home to play Tipping Point New Mexico. Thanks to Path 3 Marketing for producing this show.